talk today, I suppose, is about the things that we often don't think about when we talk about menopause. So the things that go on in the background. And I like to tell patients to think about menopause as a time to get an NCT, to get things checked out, because a lot of our life happens after that menopause. So to think about other things. So the first one I'll go through is heart health. So we all know that heart disease is common, and 1 in 4 women in Ireland unfortunately die from heart disease. And women are 6 times more likely to die from heart disease issues than breast cancer. I suppose there's lots of things that we can do to try and manage and prevent heart disease. When we talk about blood pressure is really, really common, and we tend to not know about it. We tend to have blood pressure twice as common post-menopause than before the menopause. And scarily, about 50% of women over 60 will have blood pressure issues, so it tends to be underdiagnosed. When we look at smoking, we know that smoking is one of the most preventable and powerful risk factors. People that smoke often go through menopause or have symptoms 18 months earlier than those that don't. And people that smoke tend to have worse and longer lasting symptoms. If we look at cholesterol, so as women enter menopause, their cholesterol tends to jump by about 10 to 15%. It causes everything to go off. Your total cholesterol, your LDL, and your triglycerides, and it reduces that lovely HDL as well. So it's an important thing to think about and to consider getting checked. Weight, so weight people always are concerned about, and obviously it's very distressing for people as they go through the transition. And roughly about 50% of menopausal women, and we say about 1.5 kilos per year is the approximate weight gain, and that's in everyone. So it's very, very common. Diabetes. So diabetes doubles the risk in men and triples the risk in women of having cardiovascular disease. So an important one to screen for. And then alcohol, which we all enjoy. And alcohol tends to worsen a lot of menopausal symptoms. So a lot of women that come into me, they just say they just don't drink anymore. They can't sleep, they get sweats if they do. And it also attributes to the calories that can link in with weight gain. Why does it happen? I suppose a lot of it is down to multiple factors, but estrogen definitely plays a role. And as we lose estrogen, it causes a 4-fold increase in cardiovascular disease. And again, it's important to think about. So if you look here in that lovely little slide, so the yellow are the premenopausal, the red or pink is postmenopausal. So you can see significant, as you get older, that the jump increases, and all down to estrogen. What about HRT? So HRT, as Ciara mentioned, it depends on when we initiate estrogen. So obviously at the start, if you look when we're young, we've very little blockage or build-up of plaques in our arteries, and as we get older, that increases. If we introduce estrogen too late, it's obviously not going to make a difference, and as Ciara says, we've no evidence that it increases your risk, but ideally you want to introduce it when people are in that perimenopausal phase, so that you can get what we feel is that reduced risk of cardiovascular disease and stroke in women when it's initiated under 60 or within 10 years. So that's all about heart disease. If we move on to the second thing then, which is our bone health. So again, we don't tend to have pain from issues with our bones, so many women don't know about it. And estrogen is really, really protective for our bones. So obviously as we start to lose estrogen, it becomes more of a concern. I found this one a little bit scary, but 1 in 2 women after the age of 50 will have some form of fracture in their bones, generally related to that drop in estrogen. And we lose about 10% of our bone mass in the first 5 years after our menopause. So what can we do? And there's lots of things we can do. We can have calcium in our diet. We absorb calcium much, much better in our diet than taking lots of supplements. There's loads of calculators out there to try and calculate how much do we take in. Vitamin D, we pretty much should be on it all year round. It's very tricky in Ireland to get adequate vitamin D, and testing for it, it's just easier just to take a supplement every day. A normal BMI, so funnily being overweight is protective for your bones. It tends to be the slimmer women that tend to have more bone issues. Weight-bearing exercise, really, really important. And obviously then to try avoid falls. Smoking and excessive alcohol increase our risk of bone density issues, so to try and manage that. When we should look at risk, so generally with menopausal women, a lot of women elect to get a DEXA scan. A DEXA scan is a simple x-ray, and it will generally give us an idea about some form of bone density. It's not the entire thing. It's not going to completely tell you your risk of having a fracture, but it gives us a little bit of an indication. We generally say all women over the age of 65 should get one, and then earlier, potentially depending on your medical history, your smoking, medications that you might be taking, or for example, if you go through menopause early. And then when we talk about HRT, so HRT increases our estrogen levels, and that can help prevent our bone density from being reduced. And recently they're showing there's more and more evidence that actually in people under 60 that HRT can be the most effective treatment instead of other known and commonly medications that we use for bone density issues. And if you already have bone density issues, it can definitely help maintain it. So HRT is something nice to think about. This is a lovely little picture. So we probably know in our families you have little old ladies that get smaller and smaller. If you have a family history of women like that, it's no harm considering maybe you might have a predisposition to having bone density issues. And I always think it's like the crunchy bar that you tend to get at Christmas. You just get more and more holes in your bones. But again, importantly, a DEXA scan doesn't give us all the information about our bones, just the bone density issues. But it's something nice to think about. So that is bone health. Third thing then, so sexual health. So this is really, really common, and women often find it very difficult to bring up. And I think as our keynote speaker mentioned, it is something that we need to talk about and to become more comfortable discussing. And one of the reasons why I didn't ask my mother to come here today. So contraception. Generally, you need contraception till you are no longer fertile, which is actually until your 55th birthday. Or if you're over 50 till you haven't had a period for 1 year, or under 50 for 2 entire years. Obviously, you're much less likely to get pregnant, but you do need to consider it a thing that can happen till the age of 50. And even those that have premature ovarian failure, so that's people that go through menopause under the age of 40, they have approximately about a 5% chance of conceiving. So it's just something to consider. Genitourinary syndrome of the menopause. So they recently renamed this. Essentially, this describes the changes that occur in the external genitalia, the pelvic floor tissues, the bladder, the urethra around the time of perimenopause. Important to think of it as well in women that are breastfeeding, they can have very similar symptoms. And these changes generally occur due to the reduction in estrogen levels. Some women have a lot of symptoms, some women don't. But unlike most other menopausal symptoms, they don't tend to get better with time. So the flushes and sweats and the irritability tends to go away with time. Unfortunately, we tend to be left with vaginal dryness, discomfort in that area. So if you have a look here, apologies, it's a little bit blurry. So the vaginal lining before the menopause tends to be thick, and that lovely moist word that we heard earlier from the talk. And then after menopause, it does become quite thin, quite dry, and that causes a lot of discomfort. Symptoms, so you can have all sorts of symptoms. People come in with vaginal symptoms. Commonly women say, I've been on thrush treatment for months, I'm always getting thrush. It tends not to be thrush, it's just that it's irritated, it's dry, it's sore, you've got pelvic pain, the skin gets quite thin. Sex can become really, really painful. People can have obviously a loss of libido, people can bleed or have a little bit of blood, have decreased lubrication, and then urinary symptoms where you dash to the loo all the time, you're up during the night. I had a woman last week who was up 9 times every single night to go to the toilet. So it can be really, really distressing, and that obviously impacts on your sleep and then your ability to function the next day. And then recurrent urinary infections. We commonly put women on antibiotics. And often if we treat the vaginal dryness and the drop in estrogen, that can really make them have a lot less urine infections. What can we do? There are lots and lots of treatments out there. There's the non-hormonal options. So you can see in the pictures, there's vaginal moisturizers, vaginal lubricants. Think of moisturizers like something you put on your face. It tends to last for about 24 or 48 hours. And then lubricants, they're only short acting, so you tend to need to keep using them. There's lots and lots of products. A lot of them have fragrances. Try to avoid them. We generally recommend the Yes and the Silk brands because they're quite natural, don't tend to have many preservatives in them. Obviously there's Regel, there's Replens, there's so many products out there. And then there are hormonal treatments as well available, and that's things like Invagis, which are little sticks, little tablets that you can insert into the vaginal area that gives lubrication to the area but also helps with the bladder. And it's important to think, we always think the vaginal wall gets dry but the bladder gets dry, so it's almost like you've got a dry skin on your arm. It gets irritated and it makes your brain think that you need to go to the toilet all the time when actually it's just dry and irritated. So if you can give it extra moisture with vaginal estrogen, that can significantly reduce your symptoms. And obviously then Claire will be talking as well, pelvic floor physio is extremely important. If you're having pain, there's a lot that a pelvic floor physio can help with. So just to try and think about treatments, and the nice thing with all these treatments is there's been lots of evidence recently that pretty much every woman can benefit from things like vaginal estrogen. We're now using them more and more frequently in women with breast cancer because we feel there's minimal to almost very little absorption of estrogen into your system. So the breast cancer risk is something we're not as concerned about. In England, you can now get it over the counter. So it's a nice, simple, available treatment. And up north, you can get it in an e-string, comes in a little ring that you can insert instead of having to apply it a few times a week. So lots and lots of treatments. And then sexual function. So I suppose most women that come into me, the first thing they tend to say is they have absolutely no interest in sex at all. A lot of them are very happy. A lot of them are more concerned that their husbands are not happy. But it is something that a lot of women struggle with and become quite distressing for them. We say about 43% in a recent study were sexually active, 62% were satisfied, and 28% said menopause-related symptoms interfered with their ability to be sexually active. So it is something that's really important. We tend to not talk about it, and it can be quite distressing. There was another survey done of about 2,000 women. Most of these women, 59%, were married, and the mean age was 59. 70% of them said that their relationship suffered as a result. 84% of them found sex to be very, very painful, and only 1 in 3 ever tried to talk to any healthcare professional to get help. So it's something that's there, it's really, really common, but we just don't really tend to talk about it. Why does it happen? It can happen for so many reasons. Psychologically, you can be anxious, you can be stressed, you can be worried about your body image because a lot of the weight gain that tends to happen. Obviously, if you're worried about the pain, psychologically, that's going to impact you. And then a lot of cultural issues and stigma where you shouldn't be having sex and things should stop. That can often impact relationship factors. It can be boredom, it can be over-familiarity. There can obviously be abuse present. There can be lack of privacy in a marriage. There can be lots of relationship factors. There can be medical issues. You might have sweats and flushes, and that makes you just not want to have sex. You can have headaches. You can have joint pains. You can have the vaginal dryness and discomfort that we mentioned earlier. And obviously there can be lots of medical conditions like diabetes, low thyroid, that could impact on your libido as well. And then there's lots of different myths. So there's lots of myths out there as for women. So people often say desire should always be spontaneous. And to be honest, what tends to happen with postmenopausal women or perimenopausal is that they just have no interest. So the desire tends to decrease. People often say you need to be young and fit to have sex. You don't need to ask what your partner likes. If you've no lubrication, that means you have no desire. Sex should ideally include penetration, whereas there's plenty of other things that are there that's possible. Sexual problems will always go away if you ignore them. They generally don't. And then sex toys are a poor substitute, which again isn't true. And there's more and more things out there that are available to us that can help improve the experience. So that's sexual function. And then when we talk about sexual function, women always mention testosterone. So a lot of women come in looking for testosterone and hoping that it's this magic bullet that will help, and it definitely can help in some women, but not in every woman. So generally if we prescribe testosterone, it works in about 1 out of 10 women, and it can improve libido. It can also improve energy in some women, and it can improve brain fog, but not in everyone. So I think it's always important not to think of it as the only thing that's going to fix. You generally have to address any medical symptoms, any psychological symptoms that are there. There are a few risks with it, but what we seem to find is that it's generally very safe to try. You might get, if you don't check your blood levels, a little bit of extra hair. I had a woman who used a whole sachet that had a whole hair on her chest. But if you take it normally, things tend to be generally okay. And we do monitor your blood levels quite frequently, so risks are quite low with it. Interestingly though, we don't really understand why testosterone works, because from your late 20s, your testosterone levels are low. And if we did a blood test on anyone from the late 20s onwards, they're almost undetectable. They continue on then until they hit their 70s, and your testosterone levels are back to where they were pre-perimenopause. So it doesn't really make sense. We don't fully understand the link between it, but we do know that some women that we treat with testosterone, it's relatively safe to try it, minimal risks as long as we check your blood levels, and it can make a difference. But importantly, it does take a long time to work. So if you do want to consider testosterone treatment, you need to be happy to try it for 6 months because we get minimal benefits until then. So it's an interesting treatment. When people talk about libido, it's definitely something to consider, but it's not the only thing that tends to work. So one in a box of different things that might make a difference. And then the last thing is brain health. So brain health was in the news recently because of a few different studies. There was a Danish study that came out showing that if you take HRT, you will get dementia. Not exactly true. It was an observational study, so not a very accurate study. It just made an observation. We do have very little research on dementia and HRT. There's only 3 randomized control trials, and they're the best level evidence that we have for medical treatments. There's only 3 of them available. They all show that in younger menopausal women that it's safe for the brain, that it's not going to increase your risk of dementia. That's in younger menopausal women. But we just don't have any more studies. We know that a lot of women that have sweats and flushes, you tend to be more likely to develop cognitive issues and to have issues with memory. And we know that HRT is the gold standard to treat women that have flushes and sweats. So we generally do use it, but we just need more research. So the general summary is just don't be worried about brain health, but we do not know and we don't have enough evidence. And in early postmenopausal women, we have 3 studies showing that it's safe. So that's our brain health. So I hope that helps. I suppose there's lots of different pillars. They're often not talked about. It's important just to be aware of them and to get an NCT, get them generally checked and just ask for help. And hopefully everyone else will go through a few more bits. Thank you.